So this was a 58-year-old female with dacrocystitis of the right eye. So the first step, we are going to be doing an endoscopic DCR where we create a drainage pathway from the lacrimal sac into the nasal cavity. So first step involves preparation. We are doing nasal decongestion using a solution of 1 is to 10,000 adrenal. I use a soft roll and rub it all along the nasal mucosa to create good decongestion. Initially, I start with a soft roll. Subsequently, I proceed with using Mirocell. Kindly note the anatomy. This is the middle turbinate. This is the inferior turbinate. This is the maxillary line, which corresponds to the projection of the lacrimal sac. Now, since the patient was hypertensive, I am infiltrating only with normal saline. I will be raising a posteriorly based flap from the lateral nasal wall over the area of our interest. We can see already that the elevation is good. Again, infiltration in the entirety. We want the entire region to get nicely lifted up. Using a 15 number blade, I'm marking the inferior incision, one clean cut with the blade. After this incision, this surgery involves the use of lot of micro instruments. I use the flag end of a double end knife and use it to deepen the incision. All these incisions should be bone deep. Then I'm going to be marking my superior incision. Just above the axilla of the middle turbinate is what we use as a marker. If we make our incisions in such a way, we will be able to expose the lacrimal sac in its entirety, including the fundus of the sac. Again, in a similar way, I deepen the incision using the flag end of a double end knife. Using a Rosen's knife, I connect these two incisions. After this, using both Rosen knife as well as a suction freers, I try to elevate the entire mucosa from the bone. As you can see, I'm slowly elevating the mucosa, removing all the any attachments anywhere. Now I'm using the suction freers to elevate the mucosa. Now it is slowly getting lifted up. I'm able to see the underlying bone. And just like how we do it in septoplasty, I proceed posteriorly. Now I can see I've almost reached the bony prominence. I'm elevating all along that. It's important to get sufficient area so that I can put all my instruments without causing any trauma. I'm again very careful not to tear my flap as I'll be requiring it at the later part of the surgery. I then tuck my flap around the middle turbinate. This will help protect the middle turbinate I use a mirror cell to slide it inside so that the flap is snugly fitted inside. And whenever I use any instrumentation, I don't want to be causing any trauma to my flap. Yes. So now you can see that I have got the flap in a decent position. Sufficient space has been created now. Now I'll be starting from this area, which will once I use a 3 Kerrison punch. The technique here is to attach it the lower part of the exposed area, close it without crushing it, just get a good grip and then rotate it. This is the one of the most important initial steps, as if you do it properly, it will help in the early identification of the nasolacrimal duct, which will help us in the proceeding for our surgery. Now I can see this glistening silvery white area, which is corresponds to the nasolacrimal duct. Now I focused on the nasolacrimal duct, and as I put pressure in the eye, I can see that it moves. So once I know I'm in the correct plane, I just proceed from where I left and keep proceeding above. Again, I use the Kerrison punch to get a good grip and rotate. This might take quite a lot of time, as the bone sometimes can be very, very thick. Also, I don't you don't want to be traumatizing the nasolacrimal duct or any structure behind it. Also, you don't want the flap to get in the way. Slowly, the bone keeps coming bit by bit. You want to get big chunks of bone out together. I had kept a powered instrument ready, but I didn't require to use them. Now we can see the slowly the lacrimal slack is coming into view. We want to remove bone till the our incisions which we had marked earlier to elevate the posterior based flap. My flap is nicely tucked while I can see the lacrimal sac slowly coming into picture. Slowly I keep removing the bone. I'm almost there near my upper incision now. While trying to remove the bone, unfortunately I put pressure on the sac, which caused it to tear, and the pus, you can see it came out. I know I can see that pus is trickling from the upper part of the sac, which means that I have to still have to remove little bit more bone, and then I will be able to see the place properly from where the pus came out. Slowly, I'm completely removing the frontal process of the maxilla. I can see that small incision which was created due to pressure from the carisons. Probably the sac has already been opened in that region. Some mucopurulent discharge is continuously coming from that site. A small piece of bone is still left, which I will be removing. So that I can clearly see that one puncture over the lacrimal sac from where the pus came out, which should have been avoided. I also clear off the bone around the lacrimal sac, both anteriorly and posteriorly, because I want it to be free on all sides, complete 180-degree clearance. So, since the sac was already opened, now I used a sickle knife to just extend my incision downwards. The doctor ophthalmologist obviously helping me by passing a Bowman's probe so that I know that is the site where I have to give my incision just over the site where it is tenting. So I just extend my incision downward. This step might be a little tricky as we don't have any bony support. I extend the incision nicely downwards. I can see that there is still some pus inside the sac, and also the mucosa inside is very edematous. By holding the probe gives me traction, and my incision is able to go down. So now the sac is nicely opened. But I want these edges to get everted. Now I'm doing the lacrimal syringing, and in the lacrimal syringing, you can clearly see there is free flow of fluid. Again, clear flow of fluid, which indicates that the rhinostomy is successful. Now, along the posterior part of the my lacrimal sac, I just give a small incision with the scissor, one on the top. This incision will help me avert the posterior part of the lacrimal sac. Now we can see I've given my incision and automatically that part became averted. I'll be repeating the same step inferiorly so that the sac opens nicely and sticks all around. Now I can see the inside of the sac. The, it is sticking nice. It has been averted nicely and it's sticking posteriorly. The same kind of incision given in the inferior part. Same process repeated anteriorly. One on the top. I can use a right angled pick, like I said earlier, because there is no bony support. Sometimes giving these incisions become difficult. which I had not anticipated earlier. So I used a right angled pick to give my incision over the anterior lower part of the sac. I can see my sac is nicely sticking to the posterior part. There is free flow of fluid when I'm doing the lacrimal syringing. I still feel that there might be some adhesions left inside the sac. So I just want to open those adhesions. And also I want the sac to be nicely averted. Because of long-standing infection, probably the lacrimal sac has become very edematous. You can see the Bowman's probe. So the sac is nicely open now. You need to keep using Mirocell continuously to achieve hemostasis so that you can see this is all the structures properly. Now this is the inside of the sac. Now we will be doing the nasolacrimal intubation. It is passed through the inferior puncta, and as already I can see it coming out through the opening which I have made in the lacrimal sac. I slowly remove it through the nose. We repeat the same process for the upper puncta also. Here I am and pulling out the nasolacrimal intubation. It is quite malleable, so it's not that difficult to pull it out. And see the silicone tube. Now the same procedure will be repeated for the upper puncta. You can see the movement of the stent. This was a little new to me, but ophthalmologist was comfortable with it. Just trying to give counter traction from the other side so that the stent is able to come out easily. Now we can see that the stent is coming out almost at the same location as the previous one. And in similar fashion, like in the previous case, we just pull it out of the nasal cavity. And then tie the knot. You can see that the stent has fit nicely just inside the sac. I even use mitomycin C in this case. Now it's time to replace the flap. I open it up and then use a scissor to cut the flap in half. But first I place the gel foam. I don't want any raw area. Also, I want the gel foam to provide mechanical support so that the sac stays open. I give a incision right in between the flap so as to create two limbs. Lower limb will cover the lower part of the opening and ensure that there is no raw bone left exposed. And the upper one will create the cover the upper part. And I can see the opening in between, which has been covered by gel foam with the stent protruding out. I ensure that the flap is at its correct place. To ensure that no raw bone is exposed, again I reposition the upper flap. I will be starting with saline nasal sprays from the post op day one and then reassessing the nasal cavity after 1 week. Till that time, I want these flaps to stay in position. So that's all. Thank you.